I think this would be a good line for you in the future for promoting the meeting. So I am an emergency physician, and I want to talk a little bit about the indeterminate observed zone of the ESC guidelines. And I'm going to start out by doing this in non-COVID patients, and then I want to diverse a little bit and look specifically at COVID patients. And this is unpublished as of yet, and it's stuff we've been doing and we're very interested in. So I just want to say that as an emergency doc, I'm not fond of the term observe. When you're in the ER and you come in and you have a problem and you have an indeterminate troponin, we don't put you in the corner and observe you, we work you up. And so I like the term indeterminate or continued evaluations, and that's just as an ER guy. It's not simply observing somebody. I mean, maybe they need imaging, maybe they got a dissection, maybe they got other stuff. So I just wanted to bring that up. And so in the slide, you'll see a lot more indeterminate zone, which I kind of like better, but I respect the current ESC guidelines. So I worked a lot with different companies on the whole sensitivity, high sensitivity troponin stuff, and this is just some of them. These are not necessarily current, but I've been involved in this area for a long time. And the only other disclosure is that as you get older, you like serenity. And so when I write or when I'm analyzing stuff, I like to be in a place we have up north. You just need some quiet. When you're younger, you don't mind the noise. These are the ESC guidelines, and obviously you've seen these many times, and we're going to be looking at that indeterminate observe, continue evaluation zone. What do you do with them, and how do you manage them? The indeterminate zone cut points are different from different assays. This slide's been shown before, so you need to obviously to know what your institution is using and what is very low, what is high, and what the high delta is, and then what's left in the middle, which is the indeterminate zone. So we started out doing this and looking at a large U.S. trial, which the theory was that we could harmonize the cut points that were used in the ESC guidelines, predominantly from a European population, and see if that applied to an American population, which arguably is a little bit different, not a lot, but it is, and we did that. And we actually showed that there was a great correlation, and you could take the cut points that were used in the ESC based on a European population to an American population. So we did this in the US, and we had 29 sites there, and these are listed here, so they're academic, non-academic, a variety of places. So when you look at the primary results, you've seen these sort of slides many times before. It's the number that you could rule out, that you could rule in, and the number that were left in the observation zone. What hasn't happened up until now is I don't think that people have looked at what actually happened and how the patients were managed in the ED after they were placed in these zones. So we recently published a paper that was published in the American Heart Journal looking at what happened to the people that were rapidly ruled out. So a number of them still got admitted because they had coronary disease and everyone was worried because the mother died early, et cetera. And a number of them did get some revascularization after workup. We argue in that paper that based on these low troponins, that probably they could be optimized medically and could have been managed as outpatients, but that's a whole different topic from what I'm going to talk about now. But if you read the paper, I think it might make a lot of sense. So we actually looked in detail, and what I'm going to present today is what happened to all those people that were managed by clinicians using contemporary troponins and whatever else they felt they should do. What did they do with those people? How were they managed, and what were their outcomes? And I don't think that's been looked at very much, and I think it gives you some insight into what the possibilities may be for this. This has been presented at our academic emergency medicine meeting and nowhere else. So that's what we're doing. And in our study, you had 783 people who were put in that zone. So that's a significant number of people. You know, it's about a third of the population that we actually studied. So what was very interesting, the first thing you look at, well, how were they managed by clinicians? Remember, they didn't have the high sensitivity troponin. Well, it varied by institution, which really kind of does make sense that different places have different rates of you're going home or you're staying or you're being evaluated. Whether that's based on the patient population or based on the practice of those individual places, I'm not sure, but clearly it is quite different depending on what institution you go to. These are the listing of the patient's characteristics of the ones that were sent home by the ED docs versus the ones that were sent to OBS or admission by the ED docs. And if you look at it, I mean, the ones that were admitted to observation or to the hospital clearly had a lot more comorbidities. But if you also look at it and you look at the ones that ED docs sent home, there are a significant number that had really, I would argue, significant comorbidities like previous MI, previous revascularization, peripheral artery disease, I mean, obvious vascular problems. And so of those that were in the indeterminate zone, about a third went home and the other ones got worked up. So when you look at this, you go, well, that's kind of interesting. They made a decision to send people home. How did they do it? When we look back, the ED docs who made these decisions actually only missed 2 adjudicated AMIs in the ones that they sent home. And I think that they were probably early presenters. But I would argue that's a pretty low number. That's 0.9%. And I'll also show you, they didn't send them home. They admitted them. You could argue that they missed an adjudicated AMI, but they did not send the patient home. So I think it's pretty impressive that actually without the high sensitivity troponin, docs were able to accurately, for the most part, determine who should go home based on things they didn't have before the high sensitivity cardiac troponin. And what did they use? So we looked at all these things, and these are the things that they used mostly to determine who you were going to put in the unit. And it's sort of classic in terms of age, hypertension, renal function, abnormal EKG, previous revascularization. In this study, there were no formal risk scores that were used or documented. So it was the ED guys thinking of what am I going to do with the patient and making a decision. I don't know what the weight of each of these is, but these are the things they looked at. And in individual patients, they may have looked at one of these more than another. I don't know. So then you get into the discussion of, okay, so of the ones we put in observation, what happened to them? It's interesting that different institutions had different approaches as to who should get stress tested and then who should have therapy based on the results of the stress test. And it kind of gets into an interesting discussion when you're talking a little bit about MACE events is, how do you even define them or who determines them? So we actually spent quite a bit of time looking at what happened to these people relative to their cardiac workup after they were admitted or placed in observation in the institution. And I don't do this, but I have seen over my career many times that the decision on who to stress and who not to stress is very much cardiology or hospitalist dependent. One day a cardiologist may say, we're going to stress them, and the next day a different cardiologist comes by and says, we're not going to stress them. And then when you look at this, you go, well, I don't know, about a quarter of them got a stress test. Of those, the people that had an abnormal stress test, some didn't get coronary angiography. Of the people that had a normal stress test, some did get coronary angiography. The findings are sort of diffuse. Of the people that got no stress test, and I assume it's people with previous heart attacks or coronary disease, actually some of them didn't get angiography, but some of them did, and the results are sort of diffuse. So the only point I'm making about this is when you look at the definition of MACE and how it occurs, it's not as objective as you think. I mean, there's a lot of subjective decisions that go into that, and you use that as a hard endpoint for bad outcome. So I just bring that to your attention, and I think that this part of the workup, if we could actually maybe objectify it a little more, would be much better. So when you look at the people, so then you say, okay, so we sent them home, so what happened to them? Well, if you look at the green line, I think we were pretty good in the sense that we had 1 AMI at 26 days. I don't think my job in the ER is to do something that prevents something that might happen to you 26 days later. I think that's an outpatient decision and a follow-up. And if you look at the people we put in OBS, the 2 missed adjudicated AMIs were not sent home. They were put in the hospital and were worked up. And the ones that were clinically decided to go into OBS, actually they had a worse overall outcome, I assume because they had more comorbidities that the emergency physicians recognized at that time. If you look at this over a year, I mean, it's a sick patient population if you have all these comorbidities. And over a year, you're generally not going to do well in the ones that were put into OBS as opposed to the ones that we sent home. But both of them have some significant poor outcomes. We looked at these high sensitivity troponin levels within this zone, and no matter how hard we tried, whether we looked at the initial troponin, the delta, or anything, we could not use those to predict what actually happened and the decisions that were made by the clinicians to send people home or not to send them home. We couldn't do it. And so what we say in non-COVID patients is that it's still a challenging area to determine what to do to people how to manage them that are indeterminate troponin zone. And I do think that there is something with it's an old-fashioned term, it's gestalt, meaning that after you've seen a lot of patients, you get a sense of what you might want to do with them or what's optimal for them. And I think that's what this represents, because they did not have the high sensitivity troponin. They had to make decisions. People had all these comorbidities. What are you going to do with them? And actually, I would argue they did pretty well, looking both at missed MIs that didn't go home and then looking at 30-day outcomes. So I think that there's still something to be said for using the overall clinician's assessment. I'm not sure you have to use a risk score. I would argue you need to have an experienced doc and not a junior doc, but I think this data would suggest that prior to having high sensitivity troponin, the decision-making was pretty good on how to manage people who later were put in the indeterminate zone of the high sensitivity cardiac troponin thing. So I'm going to switch just a little bit here and go to COVID. So we had a horrible problem with COVID, as many did in the Detroit area. And as has been mentioned here, there are many studies that say that if you're hospitalized with COVID, the higher the level of the high sensitivity troponin, the more likely it is you're going to die. And there's actually a very good review of that in the American Journal of Cardiology. But the troponins in these studies were mostly contemporary, and they were either drawn in the ED a day after admission, 2 days after admission. It really varied. So what we wanted to do was look at all ED COVID positive patients and look at their 28-day survival based on the initial high sensitivity cardiac troponin I that was drawn and reported in the ED. So every one of these patients had a troponin at presentation in the ED. We did this by creating our own database because we didn't trust the institutional one because some of the data from the ER wasn't in that. We were interested in acute COVID, not chronic COVID. So you had to have a positive PCR test either at the visit when you came in or within the week prior to coming in. And then we looked at troponin levels and we divided them and we used the Beckman high sensitivity assays because that's what we use at our institution. So when we looked at troponin to see how it would help us to look at 28-day survivability, we divided it into zones. But what we actually did do is divide zones in the indeterminate zone. And you can see them that they're red in red. We had lower indeterminate and higher indeterminate. And we followed everyone for 28 days, whether they went home before the 28 days and then may have died at home or were readmitted or whatever. But we had the data on everyone who was with a positive COVID, and we followed them for 28 days. So it turns out that about three-quarters of the patients actually had a high sensitivity cardiac troponin. Why? They come shortness of breath, chest pain, stuff you go, well, I don't know, I guess we should be seeing if there's any myocardial injury or something like that. And actually, if you look at it, I mean, the comorbidities are common that you see in COVID, And the presenting complaints are also common ones that you'd see in COVID. And we admitted most of the patients, discharged much less, and 2 died in the emergency department. Of the 900 patients that were hospitalized, 147 were placed in the ICU, and actually 71% of those died in the ICU. So this gives you just a distribution of the high sensitivity cardiac troponin that I was talking about. So these are the different areas that we measured. So you can see that there were a number that were less than 4, which is the LOQ for the Beckman analysis. And then there were 359 that were in the lower indeterminate range, and there were 151 that were in the higher indeterminate range. And then we looked at 3 other values. The 230 were 3 times, up to 3 times the upper reference level. Then 100 was our critical value in our institution, so we divided those above that and those in between. And actually, what we found, which was really quite interesting, and I don't think has been reported, so nobody who had an ED measured high sensitivity cardiac troponin I that was below the level, the LOQ, died within the 28 days. No one. But if you look at the 2 levels in the indeterminate range, which are the low and the higher indeterminate, it all starts to separate out. So irrespective of whether you reach the level for cardiac injury or MI in terms of the 99th percentile, there is clearly increasing badness that comes out with increasing troponin based on a single troponin. Now, I can't tell you how many of these had a type 1, type 2. I don't know if this is inflammation, but it seems to be a very different disease than just the classic rule out ischemic heart disease. And I think this is the first time this has been reported that you can actually divide outcome based on divisions within the indeterminate zone of high sensitivity cardiac troponin. So one of the conclusions we just had for this was that, again, any woman who came in who had an initial level below the LOQ survived they all survived 28 days. And then the higher the level, and as I showed on the previous slide, if you were in the highest level, it was almost a 50% mortality. So it was pretty high. So we think that future studies need to be done to try to determine how best to use these particular measurements in patients with COVID disease. But I think that the COVID disease is different than I just have ischemic disease, and with particular differences within the indeterminate range is what we found. And we haven't published this yet, and I've just been too busy. So just to summarize, non-COVID, I think that I've shown that ED physicians in the US were pretty good at determining who could go home and who needed to go in observation or admitted based on risk factors and gestalt, because they didn't have the high sensitivity cardiac troponin, and they were pretty darn good. And then when you look at COVID, we did a unique thing by studying people with acute COVID and looking at high sensitivity cardiac troponin I, Beckman assay for that, and showing that actually if you do a troponin within the ED and you get the result, that alone, and I didn't get into following up because the repeats were at various different times and sometimes hours, sometimes days, so it was kind of difficult to see what the trajectory of the troponin was, but the initial one was clearly very important in terms of predicting what would happen with patients. So I will stop here and entertain questions and comments, and would like to point out that I do think a rising moon can be very beautiful. So thank you.
Yes, there you go. A question there.
Richard, fascinating data, both sets. I think this sort of systematic study of care in patients in the observed zone is long overdue. And although the decision-making seemed good, the tests chosen were somewhat random. And I'd like you just to speculate, because if I understand correctly, in high US, none of the clinicians had access to high-sensitive troponin.
No.
They didn't know these patients were in the observed zone. What do you think might happen if you implemented a high-sensitivity pathway which created an observed zone to testing in that group? Do you think it would go up or go down? And what are your plans for implementing that sort of pathway in your center?
You know, right now, I don't know, Nick, because right now the decisions on the indeterminate zone are really based on scoring systems, etc. And we didn't have those scoring systems, and we didn't have high sensitivity troponin, yet we did pretty darn good. So how do you actually now implement that, given what's out there? But you know, we've had a lot of discussion and a lot of zoning, but we never really looked at what happened to the people in those zones with the management they had at the time. I mean, how good were people? And so, you know, I think they were much better than we thought. And, you know, and having been around a while, you know, I struggle with, you need objective data. It's great, yes. And we need scoring system, yes. But there is really something to some doc that is with an individual patient, talking to them, and has talked to many patients in their life, saying, no, I think you'll be okay, which they were, or no, I think you should stay. And then when you stay, I don't know what the right answer is as to who gets what, and that's what you do, not me. But it seems that that's also an area that is not so clear, at least to me, based on our review of the data.
Thank you, Dr. Nowak. Thank you very much. Thank you.